Hello everyone. Today we are here with Dr. Barnes. Dr. Barnes is a vascular medicine physician and a cardiologist at the University of Michigan, and we are here today to talk to him about his recent review on venous thromboembolism and anticoagulation related to venous thromboembolism in the Vascular Medicine Journal. Welcome, Dr. Barnes.
Thank you. Thank you. So we wrote a review. It was a team of us from the University of Michigan, Dr. Canthi and Dr. Freilich and myself, really trying to explore the role of extended anticoagulation for patients who have venous thromboembolism. So to do that, we did a brief review over the various stages of treatment, the acute, the immediate treatment, the intermediate or long-term, and then the extended, sort of what happens after those first 3 months. And then the rest of the review really focuses on how do you determine who's at risk for having a recurrent venous thromboembolism, what are some of the ways we can estimate that, what are some of the different treatment choices we have as far as anticoagulants and antiplatelet agents, how do we assess bleeding risk in addition to recurrence risk, and then we sort of finished up with a recommended algorithm, sort of how we approach patients when we're determining who we should be treating, how long we should be treating them for, and what agents we should be using.
Wow, that's excellent. So, could you share some of the things that you were able to develop with it? Any specific pathways that you felt could come out of your review, and any sort of differences now with all these new anticoagulants and antiplatelet agents that have been used for certain situations in venous thromboembolism? What seems to sort of stand out?
Yeah, you know, there's, I think, a lot of growth and discussion because there has been so many new developments and people are confused as to what's the right thing for the right patient. And I think that's really the key question, is finding the right treatment for the right patient. So we talk about a few different things. The first is that there are a number of risk stratification tools that sort of bring together various aspects to estimate somebody's risk of recurrence. And there are some themes that kind of run through all of them. For instance, they all recognize that men seem to have an increased risk of recurrence as compared to women, and a few other elements. Unfortunately, we haven't seen good risk stratification tools for bleeding, and so it's much harder to estimate bleeding in the venous thromboembolism patient. That's a little different than the atrial fibrillation patient, and certainly different than estimating risk of recurrence. One of the things we talked about a lot in our review paper is the role of lab testing, in particular the D-dimer test, which is a part of many of these risk tools and is, I think, often used in practice. That can be tested both while somebody's on anticoagulation. It can also be tested off of anticoagulation. So we tried to summarize all of that data as well. And then we went through sort of a review of the literature. What are the different agents and how effective are they for preventing recurrence? So warfarin is obviously very effective, and we've been using that for many years, but we now have 4 different direct oral anticoagulants, and each of them have been tested in different studies, some compared to warfarin, some compared to placebo. What's their effectiveness? And I think the overarching view is that they're all very effective. Some may be even safer than warfarin from a bleeding standpoint. We also touch on the idea of using aspirin, an antiplatelet agent, because that was tested in 2 trials. And again, positive results, effective in preventing venous thromboembolism recurrence, although I think it's also important to know it's not quite as effective as a true anticoagulant. And so there is some protection, but not as much. Yet the bleeding rates maybe are comparable, yet for some patients that could be an appropriate thing to do. So then the paper sort of finishes with a recommended approach, and I recognize this won't be the perfect approach for everyone, but it's sort of how we think about things. You know, there are clearly patients for whom a short duration of anticoagulation is most appropriate. Those are your provoked patients. It's clear that there was a reason they had this clot, and that reason can be resolved. There are also people for whom extended anticoagulation is certainly the right thing to do. People with active cancer, or people who've had multiple, especially multiple unprovoked clots. It's that middle group where a patient maybe had a first clot that was either unprovoked or we're not sure, where you can start to bring in some of these other elements. So thinking about a D-dimer, thinking about male gender, some of those elements are important. And then we really highlight the importance of having a discussion with your patient. Some patients are going to say they want to be aggressive about preventing recurrence. Other patients are going to say they really don't want to be on a blood thinner as long as they can. Some may be on aspirin because they have concurrent cardiac disease. And so individualizing that decision for the individual patient, I think, is really part of the key.
It seems like an excellent review, and I think it will certainly be very beneficial for all of us who actually take care of patients with venous thromboembolism. So thank you, Dr.
Great.
Mons.
Thank you.